And this session will be coordinated and moderated by my good friends Dr. Venkatesan and our special guest of honor Dr. Amit Malviya from Nigrin Shillong. Venkatesan is from Madras Uday College. We did DM together. He's a professor cardiologist. So we have a real legends in academic performance today. And it's my pleasure to be here this evening to share this program with you all. With these viewers, I request Dr. Amit Malviya and Dr. Venkatesan to take over the proceedings and start the session. Thank you.
Yeah. Thank you, Dr. Murli, for calling me for this your session. Your SRMC is doing last 1 month. It has been a good academic going on. I am happy to be part of it. I think the students are coming all over India, and it's a good thing we have these online programs. I think we'll go ahead with the case, and the person is from Assam, I was told, somewhere in Northeast, the student. Am I right?
He is from Shillong, Northeastern Indira Gandhi Regional Department of Cardiology. Final year student, and he will be presenting the case today. Dr. Ashish.
Good evening, respected teachers. For today's CME, we have a 55-year-old office employee who presented with chief complaint of fatigue for last 6 years. Coming to history of present illness, patient was apparently asymptomatic 6 years ago, presented with complaint of fatigue for last 6 years. It was insidious in onset, progressive in nature. Initially, he had difficulty to run. Now he has difficulty in walking 2 flights of stairs, suggestive of NYHA grade 2 fatigue. He also had dyspnea for last 3 years, which is insidious in onset, progressive in nature, increases with exertion, suggestive of NYHA grade 2 dyspnea. No cough, expectoration. Dyspnea has no diurnal, seasonal variation or any postural variation. It was not associated with pedal edema or abdominal swelling. He also had 1 episode of syncope 1 month ago in sitting posture while watching television. It was not associated with any exertion. He fell on couch, unable to recollect any history of palpitation, recovered in 1 minute without any post syncope confusion, no abnormal limb movement or no sphincter abnormality incontinence was documented. No history of palpitation, no history of chest pain, no history of neurological deficit, gangrene or abdominal pain. There is no history of fever, joint pain or rash anywhere in the body. Coming to past history, he had significant history of bronchial asthma for last 25 years. He had allergy to dust. Bronchial asthma is worsened and it required inhalational therapy to prevent exacerbation, daily inhalational therapy. There is no history of joint pain, swelling, fever in childhood. No history of cyanosis, recurrent respiratory tract infections. No history of any regular intramuscular injection in the past. No history of previous surgeries, interventions in the past. No, he is non-diabetic and non-hypertensive. No history of previous coronary artery disease or acute coronary syndrome. For this episode, last month for syncope, he received implantable device therapy. Records are not available at present. Coming to personal history, he is non-smoker and no history of alcohol intake. He is a single child born of non-consanguineous marriage. There is no significant family history. He belongs to middle socioeconomic status.
Don't go to the provisional diagnosis. Let's have a discussion on the history.
Yeah.
Sir, to summarize.
Just summarize the history.
Sir, 55. Here is a 55-year-old office employee belonging to middle socioeconomic class with no prior history of diabetes, hypertension, CAD, CVA, no history of alcohol or smoking, with no family history of sudden cardiac death, with significant past history of bronchial asthma for last 25 years, which requires daily inhalational therapy. Now, this time presented with fatigue for last six years, which is NYHA grade 2, and dyspnea for last 3 years, NYHA grade 2, with one episode of syncope for which he received implantable device therapy.
Okay, now
with this, sir.
Dyspnea, you have mentioned all the features of dyspnea, but one thing you did not tell whether he had paroxysmal nocturnal dyspnea or not. Did he have any PND associated?
There is no, sir, there is no history of orthopnea or PND.
Okay, there's no history of PND.
Yes, sir.
And this history starts with fatigue, a progressive fatigue,
yes.
Isn't it?
History starts with fatigue.
Suddenly, you said no history of gangrene. Why? I mean, just by the way, did you just use the word gangrene for what? For what purpose? What did you have in mind when you said no history of gangrene? You meant thromboembolic disorder? Thromboembolic disorder? Yes. Okay.
Sir, in the present clinical scenario, if any arrhythmia is precipitating the cause, specifically AF, that may lead to embolic phenomenon, specifically peripheral gangrene.
So there is one point in your history which says that this syncope is completely cardiac. What is that point in the history?
Sir, in this patient, the syncope is non-exertional and it was during rest, suggestive of a arrhythmic syncope of arrhythmic origin. Correct,
because if it's only cardiac syncope which occurs in the bed or in the resting state, otherwise the commonest cause of syncope is vasovagal or orthostatic, etc. So since you have clearly mentioned that it has occurred in the bed, we are sure that we are dealing with an arrhythmic syncope. And of course, for that, an ICD or whatever has been implanted. Okay.
And this is a 55-year-old man presenting with progressive dyspnea as well as syncope. Forget about the ICD history. What are the things comes to your mind in a patient who almost in a 55, right? Sixth decade.
Yeah. Sir, this patient who presented initially with fatigue, I would like to keep possibility of low cardiac output status, specifically LVOT obstruction lesions, and most probably possibilities will be acquired valvular heart disease, aortic stenosis. Second possibility I would like to keep is HOCM in view of device therapy and also syncope. And third possibility I would like to keep is dilated cardiomyopathy. And in view of bronchial asthma, long-standing bronchial asthma for the last 25 years, I would like to keep a possibility of RBOT obstruction in the form of severe PAH that may be a cause.
The patient comes with dyspnea, right? And syncope on episode. What makes you to think it's an outflow lesion? Why don't you think about a mitral valve lesion?
Sir, fatigue is one of the important
presentation
here for last 6 years.
Yeah, you tell me the presentation. You are fixed already at LVOT. What makes you to fix the probable diagnosis of LVOT with the history? Why can't be RVOT?
Has the patient become more symptomatic after the device or status quo?
Sir?
After device therapy, is the patient better, same, or worse?
Sir, I will add the history since I provided the history. After the implantation, there was no events. He remained to be. He remained to have the fatiguability and dyspnea.
Okay.
So coming back to this situation between LVOT obstruction and RVOT obstruction with regards to syncope. So how did you fix this, that this is definitely an LVOT obstruction and not an RVOT obstruction?
That's it.
That was a question which was asked.
Sir, I am, sir, from history, except for device therapy, otherwise I am also lower down, I can keep a possibility of RVOT obstruction in the form of severe PAH due to long-standing bronchial asthma.
Can you suggest device therapy for an RVOT obstruction?
Hello.
Yeah.
Hello. Can you be able to?
Can you hear? Did you hear the question?
Question.
Yes, sir. Yes, sir.
Is there any remote possibility or it doesn't?
If you don't know, you must say, I don't know.
Sir, I am not aware, sir.
Okay. See, why we asked you about PAH is because you see that the patient gives history of dyspnea. It does not give you history of PND or orthopnea, but his predominant features are dyspnea, suggesting a left-sided involvement, more likely. One interesting thing about PAH and syncope is that the patient may have all features of right-sided failure in severe PAH. He may have edema, he may have abdominal distension, and then only he will go to syncope. Whereas in left-sided, he will have syncope straight away. Of course, in this patient, things are very clear. As you said, that this syncope is clearly due to arrhythmia. It occurred when the patient is lying on the cot. So we cannot ascribe it to anything else other than an arrhythmia, rather than an LVOT obstruction. So just coming to the standard question is in the exam is that how do you distinguish syncope as a symptom in a fixed LVOT obstruction versus a subaortic obstruction or a dynamic LVOT obstruction? What is the difference in the history in syncope due to fixed LVOT obstruction like aortic stenosis versus subaortic obstruction?
So,
dynamic
syncope of fixed obstruction or in AS specifically due to low cardiac output status is exertional syncope is much more common, and in dynamic obstruction like HOCM usually arrhythmic syncope is more common.
That is, if arrhythmia occurs, yes, syncope can occur. It's quite rare, but the important thing is that the syncope will occur at the start of the exercise in fixed LVOT obstruction simply because it's an inadequate cardiac output as against a vasodilation. Whereas in IHSS or HOCM, the syncope may occur after the end of the exercise. That's an important. Many of the symptoms will occur after the end of the exercise in HOCM, not during the exercise. So that's an important point of differentiation between fixed and HOCM.
What are the other causes of cardiac syncope? Mechanical syncope, not arrhythmic. Other causes.
Other causes, arrhythmic syncope, then thromboembolic phenomenon like LV, severe mitral stenosis with valve thrombus, then mitral myxoma causing LVOT obstruction.
So you can have a myxomas and valvular thrombosis, even critical mitral stenosis. What is the incidence of syncope in a critical mitral stenosis? Say valve orifice is around 0.6 or 0.7. And what is the mechanism there? What? See, we always know syncopes are more common in the outflow obstruction. Even the inflows are, even if critically obstructed, syncopes are little uncommon. What is the mechanism? You say the fixed cardiac output and other things, right? In mitral stenosis, the 0.6 or orifice, the cardiac output is fixed or what? Why the syncope is less common in other inflow obstructions? Can you?
In other words, how is the compensation? for the inflow obstruction?
Correct. How is it compensating?
How does the heart compensate? Are there other mechanisms like heart rate? Or
Yes, sir. By tachycardia, if LVOT is not obstructed, then tachycardia can compensate for transiently for cardiac output. And,
Okay. See, the syncope's circuit has to involve the LV myocardium, the stretch, the myocardial stretch. In outflow obstructions, what will be the intra-LV pressure, cavity pressure, aortic stenosis?
LV pressure will be very high in aortic stenosis.
So
compared
that
to
actually
stimulate mechanical
that
receptors.
actually contributes to the stretch receptors. That also activates the syncope.
Yes.
Yeah. This mitral
Mechanical
stenosis,
receptor from LV, sir.
It's not exactly called Bajol-Zuri.
It is only just activation of the LV baroreceptors leading to reflex vasodilatation.
That component is usually missing in mitral stenosis because LV is underfilled, right? Okay.
You mentioned dilated cardiomyopathy as one of your differentials. So do you think the total duration of symptoms and the progression of symptoms fits in the natural history of dilated cardiomyopathy?
Sir, that's why I have kept it lower down possibility, sir, because dilated cardiomyopathy patients in natural history survival more than 2 years is very rare. It is 70 to 80% fertility.
With reference to dyspnea again, in LVOT obstruction, what is the natural history of dyspnea and outcome in valvular aortic stenosis compared to dynamic LVOT obstruction like HOCM? Onset of dyspnea and outcome.
So in aortic stenosis in natural history study, specifically by Brownell, if a patient has angina, then 50% chance of mortality in 5 years. If there is a patient has syncope, then mortality 50% in 3 years. And if patient starts developing dyspnea, then 50% mortality within 2 years.
Yeah, do you agree with this? This is a very old statistics, very old study. Yeah, quite old. See, what is the mechanism of dyspnea and aortic stenosis?
Dyspnea in aortic stenosis, sir, mainly low cardiac output status and reduced supply to respiratory muscles. Then
forward cardiac output you are telling. See, the dyspnea, if it is a part of cardiac failure, this rapid deterioration, the statistics will apply. If the dyspnea is due to simple diastolic dysfunction, again, the natural history is still better. So you should know whether the dyspnea, see, anyone can develop dyspnea. What is the dyspnea? Can dyspnea occur in diastolic dysfunction? What is the incidence of diastolic dysfunction?
Sir?
In aortic stenosis and HOCM?
Dyspnea in aortic? Sir,
I just want you to know the dyspnea can be a manifestation of simple diastolic relaxation defect. Okay. In that case, the outcome is different. And if it is a part of a LV or systolic dysfunction, that's a different. Okay.
Right.
Yes, sir. Sir, if dyspnea is due to diastolic dysfunction, also prognosis is worse than patients with systolic dysfunctions.
Is it? Okay. That can be discussed. But generally, in HOCM patient, hypertrophic cardiomyopathy, dyspnea is a very early symptom. But still the patient goes on and on, right? So that's the difference you should make compared to valvular aortic stenosis.
So what is the symptom which is predominantly missing in this LVOT obstruction, which of course patient has not given? One more symptom, if it is there, you can very confidently say we are dealing with LVOT obstruction.
Angina, angina in my patient, angina.
Angina. So angina is not here. Angina is not okay. Okay, let's go to any other thing.
Angina, if it is there, what would be the mechanism?
Mainly demand supply mismatch in severe aortic stenosis due to LV hypertrophy. There is demand supply mismatch. Then cardiac, there is a microvascular disease in aortic stenosis, and cardiac coronary reserve is reduced.
Okay.
Okay.
Okay. Can go ahead.
And in HOCM, if you are thinking what is the causes of angina, if you are thinking of an HOCM, it's also an LVOT obstruction.
Can there be angina with severe mitral stenosis?
In severe mitral stenosis, patient can have angina, sir, due to mainly due to RV ischemia due to severe PAH.
Any other reason? Any other cause?
Sir, other causes like severe thromboembolic phenomenon like severe PTE and arrhythmia, the coronary.
Okay.
So for in HOCM, in addition, everything is the same like aortic stenosis. You have mismatch. In addition, you have small artery narrowings, and there is an intramural compression of the small arteries due to severe myocardial hypertrophy. That's also one of the causes of angina in HOCM. Okay. And of course, the other reason they say is abnormal coronary flow reserve. These are the causes giving rise to angina in HOCM or as can occur in valvular AS also. Okay. Yeah, you can. Can we go to provisional diagnosis?
Then you can go to the provisional.
Examination.
So the provisional diagnosis from your history is LVOT obstruction, correct?
Yes, sir.
Okay, fine.
Can you want to put only one diagnosis as obstruction and nothing else?
Sir.
So just telling from your provisional diagnosis is a LVOT obstruction causing and no other cause, right?
Sir.
Any other?
Sir, other possibility, I would like to confirm, but I will lower down. I will like to keep possibility of dilated cardiomyopathy and severe PAH due to long-standing.
Again, I'm coming back. What are the indications for a pacemaker with a severe PAH? Can you just think what are the options you have in mind?
Sir, sometimes severe PAH with RV dysfunction can precipitate arrhythmia. That can be a cause.
No, any condition, there is a predominant right-sided pathology, cardiac failure with an arrhythmic risk demanding ICDs.
Let's proceed and see.
Okay.
Sir, coming to examination, height is patient's height is 166 centimeter, weight is 60 kg with a BMI of 23.4, which is normal. Heart rate is 80 per minute, regular in rhythm, normal volume. Pulses viscerience is present. All peripheral pulses palpable, no radioradial or radiofemoral delay. Conditions of the vessels wall normal. Blood pressure is 110/70. In all peripheral vessels, no postural fall in blood pressure was noted. Respiratory rate is 18 per minute, abdominothoracic pattern. Saturation is 98 in right upper limb and 98% in right lower limb. Patient is afebrile with a temperature of 36.6 degree centigrade.
How do you recognize pulses bisvariance?
Sir, gradually, first giving a higher pressure to obliterate the pulse, then gradually reducing the pressure so that one can feel two pulsation in systole.
Where did you feel? Is it in a carotid or brachial or radial?
Where is pulsus bisvarians best felt, or you can be sure?
Peripheral vessels.
Peripheral means what? I mean, you mean brachials or radials? See, if you want to see a type of a pulse or a character of the pulse, the best vessel is as
It's
close to the
carotid.
LV as possible, isn't it? As close to the aortic valve as possible. And that is carotid, correct? If you want to see the disease of the aorta, which artery you would like to palpate? If you want to know whether aorta is diseased, which artery?
So, peripheral vessels like radial arteries. Delia will be more pulse.
No, the character of the pulse is best seen in carotids, correct? So bisvariance is best felt in carotids. If it is very nicely felt, like AR and all, then you can see it even in brachials. But the best bisvariance is felt in the carotids. Okay, if you want to see disease in the artery, the best artery is abdominal aorta. That only will give you the disease, whether it's aneurysm or whether there is some arthritis, etc. Correct? Okay.
The moment you get a pulsus bisvariance in carotid, there are certain conditions come to your mind. What are the causes for pulsus bisvariance?
Sir, severe aortic regurgitation, aortic stenosis plus aortic regurgitation, or HOCM can produce pulsus bisvariance.
So basically, it narrows down a possibility of diagnosis. So what do you think is the mechanism for this pulsus bisvariance in dynamic LVOT obstruction?
Sir, in dynamic LVOT obstruction, initially there is no obstruction to flow of blood, so there will be one peak, and after that there is a gradual doming of the LV tracing. So that will be reflected by a slow second peak in the pulse.
Okay, you mean to say pulsus bisvariance is a sign of obstruction, or it can be present in any hypertrophic cardiomyopathy, even without obstruction?
Sir, in aortic stenosis also it can be
stenosis with aortic regurgitation you are telling.
And aortic regurgitation also it.
No, how is pulsus bisvariance is a sign of obstructive HOCM, or can it occur in non-obstructive ACM also?
Sir, in aortic regurgitation severe can also it will be present.
No, that is not the question. The question is very specific. The specific question is that you have HOCM, okay? You have AS and predominant AR, all right? What will be the difference in the pulsus bisvariance between the two?
Sir, in AR or AS, both the peaks will be same, but in HOCM, the systolic peaks will be too different.
That will be very difficult to make out in palpation. So the important thing you should remember is LVOT obstruction. Even HOCM without obstruction, there will be a very fast rate of rise. That's an important sign. The rate of rise becomes very fast. In fact, in HOCM, it has got the highest rate of rise amongst pulses in cardiology. But in spite of that, the volume will be small. The volume will not be very large as in aortic regurgitation. Aortic regurgitation is a very large volume pulse. You follow? Whereas in HOCM, even if there is an obstruction, but it's an obstructive lesion, so you will get a little small volume pulse. Although the rate of rise is very fast, but still you will have bisvariance, but the total volume or the amplitude of the pulse will be less. Correct?
Yes, that's correct. You have to note, this is a very important point to differentiate a combination of AS and AR from HOCM. Okay. Okay, go ahead.
Coming to general examination, patient is conscious, oriented. There is no pallor, icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy. JBP is 3 cm above angle of Lewis. normal waveform, normal respiratory variation. There is no hepatojugular reflux, I guess. Oral examination, normal. There is no features of infective endocarditis, no features of Marfanoid habitus, no skeletal deformities or angiokeratoma.
3 centimeter from angular alveolus is normal or abnormal?
It's normal, sir.
You
That will
have
amount
no
to-
others. You just left it 3 centimeters above. Are you going to mention anything about the A wave, V wave, or anything, or just leaving out?
Saying normal waveform.
Normal waveform, sir.
Are you surprised?
Are you surprised with the normal waveform, or there could be something else on the JVP in this sort of situation, let's say?
The history.
Sir, in, specifically, prominent A wave is expected in HOCM.
Due to prominent A waves are due to prominent A waves in HOCM. Of course, the right ventricle side of the septum can get involved. The right ventricle itself can get involved. That's one. And more importantly, you can have a Bernheim effect. Due to severe left ventricular hypertrophy, you have a Bernheim effect, and this can produce a compromise of the RV side and produce a wave. Correct? Okay.
In a patient with a hypertrophic cardiomyopathy, how important is a general examination? Is it can it be a part of a syndromic pathology?
You know, you classify that HOCM into genetic or familial, non-genetic, non-familial. So if it is part of syndrome, what are the things you look for? You've already said one thing in the general
Complex
examination.
syndrome and Donan syndrome, these are syndromic association of HOCM.
What are the syndromes, you know? Any neurological syndromes can be associated, or at least.
Sir, Friedreich ataxia.
So yeah, whenever you have a myopathy, after all, cardiomyopathy is linked to systemic myopathy also sometimes, not exactly HOCM, but you should always look for other system findings, especially in patients with hypertrophic cardiomyopathy. Okay.
You have already mentioned angiokeratoma. That is for? No angiokeratoma. What is that for?
Fabry's.
Yeah. For Andersen-Fabry's disease, that is in fact quite commoner than what we thought it was, because it's eminently treatable also, isn't it? Okay. Thanks.
Okay.
Coming to cardiovascular examination, chest is symmetrical, no chest wall deformities, tracheal position appears normal, apical position is not visible, pericardium, no visible pulsation is present, device palpable over the left pectoral region, no redness, linear scar over the device implantation site is present. On palpation, trachea and apical position confirmed. Apex is 4th intercostal space, half-inch medial to mid-clavicular line. Double impulse is noted. Then no parasternal hip, no palpable sound. Thrill over second intercostal area is present. Coming to percussion, left second intercostal space is normal. Right head border corresponds to right parasternum, and left head border corresponds to apex.
When you say double apical impulse, what exactly you mean? Can you elaborate?
Sir, double apical impulse is particularly seen in HOCM patients due to increased LV mass and due to presystolic pulsation. Two apical impulses are felt in apical area.
So you are telling the double apical impulse, one impulse in systole and one in diastole. Am I right? Is that the way classically how come apical impulse is there? What is the mechanism of double apical impulse?
So the actual thing of a double apical impulse is that there should be two in systole. That's what it means really. But you don't get that often. What you usually see, you see two impulses, but that is actually a palpable S4 and a apical impulse.
Yeah.
But the strict definition of a double apical impulse is that there should be two impulses found in systole.
Very rarely you may be able to clinically, if you put an apex cardiogram or something, you may be able to pick up the fluxion 2 in systole. And sometimes it's often referred to, many of them may agree, may not agree, triple apical impulse also used to be described like that, including the atrial impulses.
Now I'll ask you one question. See, S4 or pre-systolic pulsation is produced when the atrium will contract, isn't it? Atrium will contract very strongly and expand the ventricle. So the ventricle has to expand. In HOCMD, already the ventricle is very thick. How does it expand and produce an S4? You follow my question?
Sir.
The ventricle is hypertrophy, atria are contracting, and S4 is produced at the ventricular level. It is not produced anywhere else. But you do hear S4, you feel an S4. Why do you get the S4 there in HOCM? Can you think of the cause? So the answer is that at that portion of the left ventricle is not uniformly hypertrophy. So the lateral and the superior portions of the left ventricle are easily expandable. So the atrial contraction can easily expand the rest of the LV to produce an S4. Okay? Yeah.
Okay.
Coming to auscultation.
Yes.
First heart sound is normal. Second heart sound is normally split. Normal A2, normal P2, normal splitting. Third heart sound is absent. Fourth heart sound is present. And there is no click or any other added sound. On auscultation, ejection systolic murmur grade 4/6 present in right second intercostal area with mid-peaking murmur, not radiating to carotids, increase with Valsalva and in standing, and decrease in intensity with hand grip. Other system examination.
Just we'll stop here with for the dynamic auscultation. That it's not complete in the sense that when it comes to the examination, when you're presenting the exam, you may have to tell a few more points about this dynamic auscultation with the presence of the ejection systolic murmur. If you have to make a diagnosis of HOCM, that's what you are now telling, isn't it? That it increases with Valsalva. So you must be sure whether it increases with the straining phase of Valsalva, because there are phases of Valsalva. Clinically, only two phases are there: the strain phase and the recovery phase. Correct? So you must mention with that. Secondly, the important thing is not just standing. The characteristic behavior of the murmur, you have to do a maneuver in the examination at least, or if asked, you must be able to tell. This is called as stand and squat, or squat and stand. You follow? So, but we have made it little better. We say standing, squatting, and then standing, because obviously you can't squat without standing. No, you can't stand from sitting position. So it is squat and stand. So that behavior you must elicit for the patient, and make sure the patient doesn't hold anything when he squats, and you have to squat along with the patient to auscultate the murmur in squatting. And then as the patient stands up, you'll have to, you also stand up and see the increase of the murmur on standing. This is a very characteristic maneuver, and this is better than Valsalva, mind you. The stand and squat, or the squat and stand maneuver, is very characteristic of showing the dynamic feature of the obstruction. So always do that in patients of HOCM, whether it's there or not, but you'll have to say that this is called squat standing maneuver.
Why does this murmur increases in standing? Anil Selva.
On
What
standing.
is the hemodynamics behind this?
Sir, any maneuver which decreases the LV cavity size will increase the murmur, sir. On standing,
Okay,
there
you
is
know the preload. Okay,
preload.
the preload dependent, inversely related to the preload. Okay. Do you want? You are having only one murmur, you said. Do you expect any other murmur? Did you look for any other murmur in this patient?
Sir, MR murmur is also expected, but there is no murmur of MR.
You looked for it. Where did you look for it, and how that murmur will be? Is it how often you can auscultate two murmurs in a patient with hypertrophic cardiomyopathy?
Sir, pansystolic murmur in apical areas, blowing type, and
You think it's only a left-sided murmur and not a right-sided murmur?
What is the characteristic of
characteristic ESM murmur? If it starts with A2, then it is left-sided. If it is with
starts with?
Sorry, and this is ESM murmur. Here, right second intercostal space. This also signifies left-sided aortic area.
The murmur is so high in the second space, grade 4/6 in second, and you say it's left-sided murmur. Can you justify it? How to explain this murmur?
Sir,
Or you want to give any other differential diagnosis and any other source for the murmur?
If you just keep a grade 4/6 murmur in the second left intercostal, present in the right second.
Right intercostal.
Okay.
See.
aortic areas.
Whether it's a valvular or subvalvular.
Sir, usually subvalvular murmur is present. Usually left third intercostal space is best to get HOCM or subvalvular murmur. But in this case, it is present in right second intercostal
So
space.
are you dealing with aortic valvular murmur?
Yes. Sir, possible, sir. At present, there is no point to exclude aortic stenosis murmurs.
Okay,
But one point against carotid murmur, no radiation to carotid is against aortic stenosis murmur.
Very
That's the
unlikely.
dynamic nature.
Yeah, I think the clinical findings can vary. Very unlikely to have a right second space murmur.
Yeah, you keep the option of differential diagnosis.
Open.
We're not bothered about the final diagnosis. We want the options.
Yeah.
So what is the characteristic of the MR murmur in, say, HOCM?
Yeah, that's important.
In HOCM,
In fact, there is always a doubt whether it is due to primary mitral valve abnormality or it is due to the effect of the SAM, etc. No? Even on echo, you'll have to make this out. So what is that characteristic of the MR murmur, which is very characteristic of HOCM?
so the MR murmur is usually starts after sometimes after S2, sir.
Yeah, occasionally it can be late. I agree with you. It can be
Sir,
little late.
delayed systolic murmur with no radiation and no thrill, sir.
Okay. So the MR can be in HOCM can be due to MVP also. MVP is also associated with HOCM. It can be due to the primary mitral valve abnormality. But if it is due to the pull, then it is characteristically what it will happen. It will radiate laterally and posteriorly. This is an important point to keep in mind. Even when you look at the echo, a lateral and posterior deviation of the MR murmur is very characteristic.
From your physical findings, do you think it's an MR murmur? from what you described, do you think it's an MR murmur or aortic valve murmur or subaortic murmur?
This is from location wise, this is valvular aortic stenosis murmur.
Okay. Yeah, location wise, yes, you'll have to keep this in mind. All right. From the now, you didn't get any MR murmur, you got only a ejection systolic murmur.
Yes.
Fine. But it has the same dynamic auscultation features which you did and showed that it has the features of HOCM. Okay. What is the other dynamic auscultatory features? Like, what is Muller's maneuver?
Yes, sir. Muller's maneuver.
What happens to the murmur on Muller's maneuver, HOCM murmur?
In Muller's maneuver, also it like similar to Valsalva maneuver. In Muller's maneuver, also it
It will increase. It increases, but it's not very difficult to demonstrate. And on carotid sinus massage, what happens to the murmur on carotid sinus massage?
Rate will decrease.
Rate decreases. So
decreases. So feeling will increase. So
murmur will increase.
Murmur will decrease.
So it's not very sensitive, but these are sometimes. Okay. Fine.
Next.
In respiratory system, there is bilateral basal crepitations present, and air entry is equal in both the side. Per abdomen examination, liver is not palpable. Total liver span is 10 centimeter, which is normal. No pulsation felt. No splenomegaly. No free fluid detected in abdominal examination. Neurological examination was within normal limit, and there was no ataxic gait.
Okay. Now, before you go to final diagnosis, we should have a discussion on how to present this final diagnosis in the exam. Okay. Always you start final diagnosis either rheumatic or congenital or whatever it is. How will you present if you want to say HOCM on the final diagnosis? Will you say it's congenital or whether you will say it's acquired? What will you say?
Sir, for HOCM, I will say acquired heart disease, left ventricular outflow tract obstruction, HOCM, likely obstructive, with diastolic dysfunction grade 3, with grade 3 PBH or moderate PBH, with no PAH, with normal LV function, no evidence, patient is in sinus rhythm, NYHA grade 3, NYHA 2 in my patient. And there is evidence of congestive heart failure because muscle crepitations are present. No evidence of infective endocarditis, and no precipitating factor or worsening at present.
The question is that is HOCM congenital or acquired? Or acquired on the basis of a congenital problem? Or it sows the seed in congenital and then becomes acquired, like Marfan syndrome, etc. So the best way, in my opinion, of course, it will vary from exam to exam and what the other examiners feel, is to say structural heart disease. It doesn't matter. You say structural heart disease with left ventricular outflow tract obstruction. Okay. That would be a safer presentation than to say it's congenital or acquired. Of course, you know very well it is congenital, and it later on the hypertrophy sets in, isn't it, as the child grows. So that is the argument. I don't know what Dr. Venkatesan or Murthy will say about this, or of course.
Yeah, it's phenotypically it is represented later. The genetic defect is already there. So what you say is correct, sir. We can use the same term. What
do you say, Dr. Amit? How do you teach people?
Sir, we normally tell them the way you have told. We tell them to say structural heart disease, and then tell about the valvular lesions wherever their location, then whatever points he has said. Because there are certain points where there's always confusion between examiner to examiners.
Correct. That's what we have to. Okay.
Before you go to your diagnosis, what is not fitting from your clinical presentation and the expected diagnosis? From your clinical thing, there's not much of cardiomegaly, and JVP is normal, blood pressure is normal, there's no murmur, S3 is not there, except an ejection systolic murmur on the second right space. And at the same time, you are thinking more in terms of hypertrophic cardiomyopathy with a past history of an ICD or pacemaker, whatever it is. So putting all that, can you go for your diagnosis?
Sir, what is odd in the presentation of HOCM in these patients?
Yeah.
Yes.
Sir, one is very late presentation, sir. Usually they will present early around 30s. They will present.
Then
the classical recurrent angina is absent in the presentation. Then in examination, actually subvalvular presentation like murmur should be in third left intercostal space, and that is absent, which is not suggestive of HOC.
One participant has raised his hand, so we like to hear him. He wants to ask.
Ganesh Nabirajan.
Yeah.
Yeah, good evening, sir.
Good evening. Good evening.
Yeah. Sir, I would like to suggest that it is a bimodal presentation rather than the student. It is not the 30s. I think it is the bimodal presentation. Either HOCM presents very early in the infants and the younger age, or in the 50s and 60s, I think, if I'm correct. I think you will agree. It is a bimodal presentation, HOCM, hypertrophic obstructive cardiomyopathy.
Yeah, usually, actually, the presentation ranges from infancy, even infancy, to the adult age. And those who are syndromic or those who have got, they will present early. And of course, as you know, HCM can be diabetic mothers, also infants of diabetic mothers. Then later on, it presents a little later. But whatever it is, as the growth occurs, the LVH occurs. That's the characteristic of HOCM. As the growth of the child and the growth of the individual occurs, LVH occurs. And of course, the other compounding factors are hypertension, etc.
Okay.
So number one is the presence of this murmur is a little against. Number two is that it has presented with fatigue, very early onset of syncope, no family history. All this a little deviations from the usual presentation. Okay. So you'll have to think of something else, because the thrill and murmur of the second right intercostal, as Murthy correctly said, it doesn't gel with the classical HOCM, because the murmur's classical location is at the third and fourth left intercostal space, correct?
So combined valvular and subvalvular.
What will be the subvalvular membranes, discrete subvalvular obstruction behavior? What are the characteristic feature? In other words, IOT regurgitation is common in which type of LVOT obstruction? At what level? Valvular, subvalvular, or subvalvular?
In valvular aortic regurgitation association is more.
No, it's subvalvular, it's always present. Please keep this in mind.
Subvalvular is almost always.
Almost always you will have aortic regurgitation in subvalvular of the membranous type. Valvular, it can be there or not there, no? Like bicuspid aortic valve, you can have P stenosis. Similarly, even tricuspid valves you can have there. But here in subaortic stenosis, due to fixed or membranous type, you'll always have aortic regurgitation.
Anyway, still we don't have explanation for the right-sided murmur, sir. Flow murmur.
Can you proceed further with your investigations?
Yeah, we'll go.
So this is 12 lead ECG, 3-channel with standardization of normal standardization to 25 minutes per second and 10 mm is 1 millivolt with a rate of 60. Rate of
Yes.
77.
It's already written there.
65 per minute. Normal sinus rhythm, sir. Regular rate is 65. Regular sinus rhythm. Axis is
Axis is?
60.
Why are you stuck at axis? It's so obviously coming there in front of you.
So, left axis deviation is there.
No, you can tell the exact axis. No, lead 2 is completely equiphasic, isn't it? Lead 2.
So
AVL is strongly positive.
AVL positive, sir.
So it is
So-
minus 30, correct?
Minus 30, sir.
Okay.
What are the chambers enlarged here?
There is a features of there is no features of RA enlargement or LA enlargement. There is a features of ABL criteria for LVS is there with T wave inversions in ST depression and T wave inversion in V4 to V6 and T wave inversion is asymmetric and not like ischemic changes, and in ST depression also initial step pattern is there, so not suggestive particularly of ischemic origin, and QT is normal.
What are the ECG changes you expect in a patient with hypertrophic cardiomyopathy? What are they?
Sir, in septal form, we expect Q waves in precordial leads. In normally RA enlargement with LV enlargement, shortening of PR, then T wave inversions in mid precordial leads, and
The Q waves you mentioned, what is it called? If you see in a hypertrophic cardiomyopathy, what is the mechanism of the Q waves?
due to increased septal mass, sir, the Q is
it infarct?
deep and pointed. Due to increase in septal mass, there is a deep Q waves.
We call as pseudo infarct, right? So Q waves are represent myocardial fibrosis, myocardial disarray that goes for myocardial fibrosis that behaves like a electrically inert, so develop a Q wave. So Q waves you can expect gross LVH. This ECG is not, is it typical of SCM or you want some more features here? What are the typical features? The LVH should be still more gross. What will be the T wave in, how does the, looking at the T waves in leads?
Deep Q wave inversions in mid precordial leads, that is absent here.
How does the ECG help you to diagnose different types of morphological aspects of hypertrophic cardiomyopathy? You know, there are multiple types, morphological types.
Yes.
One is, sir, in HOCM, classical picture is RA enlargement with LVH. And second, in septal form, there will be deep Q waves in precordial leads. And in apical form, mid-precordial lead will have deep pointed T-wave inversions with large QRS complexes in precordial leads.
Deep T-wave inversions are more common with the apical forms than the other forms.
Classical, it's called Yamaguchi
Classical.
syndrome. So Dr. Dayasagaran has raised his hand. Dayasagaran Ekambro.
Yes.
Want to say
Yes,
something?
Ask some question. Yes,
Hello.
Please
Okay.
go
Can you
ahead.
unmute and speak?
Please go ahead and ask.
Okay. Then we'll.
Is there any other electrical abnormality you look for in a patient with hypertrophic cardiomyopathy, ECG, associated anomaly, or markers of that are prone for arrhythmia?
Sir, RBBP and LBBP pattern, LA left anterior hemifascicular block, then WPW pattern.
Yeah.
Sometimes.
There is a specified, even though low incidence, there can be an association of WPW.
One of the
Suppose
One of the participants has pointed out to T-wave alternates. Is it there? You like to say? I don't know whether T-wave alternates is there.
It should be in a long strip. We can
Long strip. Here it's difficult to make out. I don't know.
Suppose you find atrial fibrillation, Dr. Ashish. What would be your interpretation in this patient, in this ECG?
Patients of, sir, can you repeat?
I'm saying if you find, suppose, atrial fibrillation on this strip of ECG with a patient with HCM, what would be your interpretations regarding stage of disease, prognosis?
How does it affect the natural history, atrial fibrillation?
Yes. In other words, how does atrial fibrillation affect the natural history?
In patients with atrial fibrillation, patients of HOCM develop atrial fibrillation, then atrial kick is lost and the patient presents with recurrent pre-syncope and syncope.
Is it like that?
Is it found in the early stage of disease, or it is found late in the course of disease? Is it a good prognostic marker? Is it a bad prognostic marker? Are they prone for atrial fibrillation, or it's very rare?
If his HOCM patients are prone for atrial fibrillation.
Dr. Hashish, looking at all this, what would have been the indication for pacemaker for this boy, this patient? Now you know the background, you know the ECG, and what would be the reason why they would have given a pacemaker?
So in ECG wise, there is a severe LV hypertrophy. So that may be one of the indicator. Otherwise, there is nothing I can say. It is.
Dr. Abhijit.
Yes, Abhijit.
If the LV septal thickness is more than 30 mm, that is that you can take for indication for AICDs.
Yeah, he wants to know the deep S waves in V5 and V6, Dr. Abhijit.
Yes,
Yeah.
sir.
The different type of morphology of hypertrophic cardiomyopathy we know. Probably that might indicate there could be an involvement of right ventricle also. That may be
Because S waves in V5, V6 also tells
we
you
don't
that.
know as such. We don't know because it's not very classical. After all, hypertrophic cardiomyopathy is a cardiac muscle disorder. It doesn't need to spare the right ventricle fully.
Correct. So that could be one. Secondly, it could also be a left anterior hemiblock because the outflow tract is damaged. So you get a HOCM, you may have a left anterior hemiblock, and that can also produce a S wave in V5 and V6.
This could explain the location of Momosa on right side.
You have a look at the echocardiogram.
Still, we are not. The other thing is pre-excitation you have to look for, and pre-excitation, you can have a right-sided pathway or a left-sided pathway. And you know that the right-sided pathway is beneficial, left-sided pathway is not beneficial in HOCM. Okay.
I guess this patient was put on a ICD, not a pacemaker. Indication was for an ICD, right, sir? Not for a pacemaker.
That's why somebody said T-wave alternance. So if that is really there, then it's a very solid sign that patient has had a ventricular arrhythmia and had a syncope, and then requires an ICD.
Some ECG, X-ray or echo? Yeah, X-ray.
X-ray also. Yeah, we can discuss X-ray of him.
This is X-ray PA view with inspiratory film, normal exposure, no rotation. This shows cytosolitus libocardia. Right heart border is normal, left heart border is normal. There is no aortic calcification, no calcifications in, no chamber enlargement. There is AICD device, AICD device put to left
What is the CT ratio?
area.
Can you guess, sir?
With SBC with
No, you just go a little systematically. You said cardiomegaly, you should take the CT ratio, then you should come to the chambers of the heart.
Sir, there is no chamber enlargement, sir. There is no lung field shows mild cephalization, grade 1 PVS is there, but there is no evidence of PAH.
I believe there is a cardiomegaly. Did you measure that? Only if you can measure, you can tell that's like. What is the importance of cardiomegaly in a patient with hypertrophic cardiomyopathy? A good sign or a bad sign?
It's a bad sign, sir. In long-standing HOCM, LV dilatation may be there. It is a burned out HOCM. That is a bad sign.
Is there any evidence of pulmonary venous hypertension? We've been talking about diastolic heart failure.
Sir,
Is there any aortic stenosis?
there is no aortic calcification or aortic dilatation, so ascending aorta dilatation.
So that favors?
That favors HOCM, sir.
Pulmonary hypertension is one of your differential diagnoses. Do you think it's there?
Pulmonary arterial hypertension. There is no evidence of pulmonary.
Is it there?
No, sir.
No.
Where will you look for aortic valve calcification, if at all it's present?
Sir, in X-ray line drawn from left cardiophrenic angle to hilum of the lungs, if aortic calcification will be above that line.
Okay. You don't expect aortic valve calcification in this patient anyway. Okay. Shall we move on to echo, sir?
Can we go to echo, please?
Sir, this is parasternal short axis view showing gross hypertrophy of LV. This is
Why did you go first to short axis? You recorded this?
No, sir. This has been recorded by.
Okay.
He has not recorded that.
By yes, Venkatesan. We showed in the order. Sorry.
Okay.
Sir, this is 4-chamber apical 4-chamber view showing gross LV septal hypertrophy, and there is anterior mitral septal leaflet movement, anterior septal motion of anterior leaflet of mitral valve.
How do you recognize systolic anterior motion best in echo?
Best view is to see sir M mode with to record anterior.
I don't know whether it's there or not.
This is parasternal long axis view showing gross.
Tell me what is the definition for asymmetric septal hypertrophy?
Sir, septal hypertrophy more than 13 mm and normal more than 15 mm and normal posterior LV wall that signifies asymmetric hypertrophy.
What is the ratio between septal and pulmonary posterior wall?
Normally it is 0.9 to 1.
Point?
Come again, 0.9 to
1. Sir.
Okay. So now, can you show the long axis view? This is for, yeah.
There is a clear-cut anterior septal motion of mitral leaflet, and there is a suggestion of hyperechoic spots in area where it is touching the LV, and there is no aortic valve calcifications.
So aortic valve appears normal. Did you note for mitral regurgitation? That was the one we were discussing. Can you show that parasternal long axis, the color flow?
The M mode, ma.
You got my Murli, can you hear? Murli?
Yeah, I get it.
Okay. You have
can
to video, you have to on my video if you want.
Preetham, can you do that? Sir's video should be strong.
Doesn't
Preetham,
matter, you can hear, no? It's all right.
yeah, we can hear. We'll switch it on, sir.
Sir, now you can switch it on, sir. You can switch it on now.
You can switch it on, sir.
Yeah, fine. You go.
Yes, sir. You are.
Thank you.
Can you show the M mode? Can you show the M mode, Preetham?
We have to show the gradient where Doppler gradient also not seen.
yes, previous. Yes.
Yeah.
Yes, this one.
Now tell us tell us about this gradient.
So this is a spectral color Doppler view taken at in apical 5-chamber view in LVOT. It is showing dagger sepet.
Are you sure it is LVOT gradient? Or I am telling different one. I am saying it's a mitral regurgitation gradient. How will you differentiate? See, what is the gradient you are picking up now here?
Here actually two gradients are given, sir.
Huh?
One is 167
167 millimeters of gradient across the LVOT.
Sir.
How often we see that in hypertrophic cardiomyopathy?
Very huge gradient.
Sir.
See, there is always a possibility of mixing of the two gradients, LVOT and mitral regurgitation in hypertrophic cardiomyopathy.
Yeah.
So the gradient which goes full entire systole, it may be a mitral registry. I'm not sure about it. Anyway, what is the mechanism of the dagger shape you are telling?
Sir, initially there is no obstruction to the flow. In fact, jet speed is very high, and later due to dynamic obstruction there is plateau. So this gives a impression of dagger shape in CW continuously.
Okay.
Actually, when you do the echo in HOCM, you must take the short axis from apex to the base. That's very important, because then all types of hypertrophy are diagnosed. Of course, now you have CABR, you have other methods. So, but when you do the echo, always do the short axis from apex up to the base. That will give you all the patterns of hypertrophy, whether it's apical, it's a mid cavity, then it's the usual place of the obstruction. Okay.
So this is M mode.
Yeah, M mode. Yeah.
So this is M mode showing significant LV septal hypertrophy with anterior septal motion, mitral leaflet, which occurs more than 30% of the, it is more than 30 in contact with the LV septum, more than 30%. So it's a type 4 anterior septal motion.
Okay, so significant SAM is there, so you can say. Did you look at the left atrium? What is the importance of looking at left atrium in a patient with glaucoma? Can you show the
Due to dysfunction, LA may be enlarged due to LV, LA pressure,
Yeah.
high LA pressure.
And I think
in this view, sir, there is LA enlargement. Evidence of LA enlargement is there because it is more than aortic diameter.
so left atrial enlargement can tell us how much diastolic dysfunction is in this given patient, right?
That's one question about how to diagnose clinically severity of HOCM. Somebody had asked. Anyway, we'll come to that. Now, in the echocardiographic patterns, I'll just ask you just a few questions. One is, if you have severe hypertrophy and if you have low voltage on the ECG, what is the diagnosis? You have severe LVH with low voltage on the ECG.
Sir, infiltrative disease like Fabry's or Pompe's disease?
No, not Pompe's. It's amyloidosis.
MLS.
In Pompe's disease, you'll have severe LVH with severe voltage with pre-excitation. This is the thing. The second question is whether you have IVS showing flat motion in HOCM, correct? IVS motion is reduced. Left ventricular posterior wall motion is increased. Can you see here? The IVS is completely flat. The left ventricular posterior wall is increased. In which condition you get reverse of this, where the left ventricular posterior wall is flat and the IVS is showing hypermobility? Which type of cardiomyopathy you get this?
It is septal splash.
ARVD, sir?
It's not found in India. It's not found in Asia. It's not found in Africa. It's not found in North America.
Chagas.
Yeah, Chagas. It's Chagas. Chagas cardiomyopathy. Okay. Okay. Next. So there was one question on how to diagnose what. Okay. Second.
Sir?
The audience. No, there was a question from audience. We skipped it, but if they want, they can ask again. How do you diagnose clinically? It came, but it went off. Okay.
Yes, clinically, the signs of obstruction would be, as I say, the first pulsus bis variance, bifid apical impulse, palpable pre-systolic apical impulse. So all this would suggest a significant obstruction. And the murmur intensity may correlate with exercise-induced increased gradient also, it can correlate. And the degree of LV enlargement will indicate late stages of HOCM. as such, yeah, that's what I'm answering. So these are the signs with which we diagnose severity of the aortic stenosis, hypertrophic cardiomyopathy.
And to differentiate between athlete's heart and hypertrophic cardiomyopathy is also a question. And the important answer to that is athlete's heart will show dilatation of the LV cavity, which HOCM will not show. Correct? And it will revert to normal once it can revert to normal, the athlete's heart.
Late peaking of murmur has no correlation with the subaortic dynamic of obstruction. Late peaking goes with valvular aortic stenosis severity.
What is the strain pattern of HOCM now that everybody is into strain, LV strain?
This is LV. Longitudinal and radial strains are affected in HOCM.
Pardon?
Strain is reduced, sir, in HOCM patients.
Strain is GLS. Global longitudinal strain is
global. Longitudinal and
what happens? When does the left ventricle goes for dysfunction in hypertrophic cardiomyopathy? Early stages or late stages?
In late stage, LVD, systolic dysfunction starts in burned out phase.
Actually, as you correctly said, that GLS is decreased, but the EF is normal. And later on, the circumferential strain can get reduced. In fact, using strain, you can't diagnose mutational HCM, but I'm forgetting the. I'll let you know later. Okay.
Yes, someone is asking. Dr. Prabhu, somebody is asking some question.
What's the LVOT gradient in this patient? So what will you do?
So in this
Ashish,
patient,
how will you proceed to treat?
so in this patient, LVOT gradient is very high. Documented is around 160. So patient patient age is two options: either surgical myectomy or alcohol septal ablation can be considered this patient, because patient is already on AICD therapy. So in this case, patient I would first consider septal ablation, because age is around 55 and the gradient is very high.
Okay.
Would you like to do any other investigation before you decide the treatment, or you can decide now?
Sir, patient SCD prevention is one of the important component of HOCM management, and patient is already on AICD. So before that, for prevention of SCD, then primary prevention, TMT or exercise test, then Holter testing are
We
to
are
be
not
done
talking
before.
about prevention of SCD here. That part is already taken care of. ICD already been put. Now, to take further management decisions, would you like to subject this patient to any other investigation to give you help in making a diagnosis, whether you want to do surgical myomectomy or you want to go for alcohol ablation?
I would like to, sir, I would like to see the coronary anatomy, whether patient is suitable for alcohol septal ablation or not. For that, I can do CT coronary angiography or conventional catheter guided.
What is the role of MRI here?
Sir, functional MRI can decide the structural disease, and And also through MRI, late gadolinium enhancement can give us idea if it is more than 15%, then we can go for AICD as well. Prevention.
So all these things are probably related to putting an ICD indication, and you want to put an ICD. Now, what is the indication for doing a surgery here right now? What is the symptoms now? Which class he is in now?
Patient is in class 2, sir. Actually,
You do a surgery and remove the alveoli obstruction. What is the purpose now here? You want to prevent. What are the likely complications this patient is likely to go from now on? He is 55. Huh? What is his age?
sir, heart failure, stroke,
Yes,
heart failure, stroke, and
arrhythmias and other things. So you have to take care of that. So you should know the indication for doing a surgery. What is the outcome of surgery? What is the complication rate? And how do you do that? What surgery? What is the name of the surgery?
compared to alcohol septal ablation, the complications like complete heart block is more common with alcohol septal ablation. Then long-term class, NYHA class remains same for both. And long-term prognosis is gradient is more reduced in case of myectomy, and long-term decrease in gradient is up to 15-20 years. Gradients remains low and patients remains symptomatic with myectomy compared to alcohol septal ablation, where a patient may redevelop a gradient and procedure has to be undertaken in some cases.
How much myocardial mass is removed during surgery? In Maro surgery, it's called Maro surgery, right?
Maro procedure.
Yeah. How much myocardium you need to take to produce a symptomatic improvement?
Usually 10 to 15 grams of myocardium is
less than 10 milligrams.
What is the complication when they do it?
Complication of, sir?
When you do the
Complications of surgical
procedure, what are the complications? Surgical complication.
Sir, VSD, development of VSD.
No,
and
not
AR.
that much, man. Not that much.
Sir? Complete heart block can sometimes develop in patients. If patient has previous RBBB, then if more myocardium is taken, then patient long-term.
If the patient has complete heart block, nowadays there is a trend to put his bundle. No, would you like to keep the lead in the his bundle? Patient has complete heart block. HOCM patient. Can you do his bundle pacing? Everybody likes to do his bundle now. They are waiting for an opportunity. This is one condition in which necessarily the right ventricle lead has to be kept in the apex. Why? Because whatever be the benefit, you have to pre-excite and produce a good LBBB pattern. Then only you can reduce the outflow obstruction to some extent, although it has never been proved satisfactory. But usually, this condition, when there is a complete heart block, try to keep the lead only at the apex, not anywhere else, not even septal pacing. It's only apical pacing. Am I correct, Murli? Murli is here or is okay?
There was a time, there was indication. Yeah. Dual chamber pacing in this year.
You want to be purposely unphysiological and asynchronous pacing. I mean, asynchronous LV active.
Yes.
The role of dual chamber pacing was there previously. What is your comment about? Okay. Hello.
Ashish?
Is there a role for a dual chamber pacing?
Dual chamber pacing was considered in some patients, but presently dual chamber pacing is not
popular. It has not been found to be useful. Okay. What is the medical management for hypertrophic cardiomyopathy? What impact it is making actually?
So for medical management, beta blockers are the first line of treatment. And,
okay.
Then,
sir, judicious use of calcium channel blockers, specifically verapamil. Disopyramide is also tried. And
So non-DHP CCBs, non-DHP calcium channel blockers. Yes, then beta blockers, disopyramide, non-DHP calcium channel blockers. Then
sir, disopyramide is also known to reduce the
disopyramide.
LVOT gradient. Then
How does
recently myosin ATPase inhibitors.
Yeah, what is a trial called? It came on JACC June 2nd, I think, 2020. Have you heard of Maverick HCM trial or Explorer HCM trial? The two trials which have come.
I've not gone through, sir. I've heard.
I mean, it's still, it's still exciting, but it's not. It's a drug called mavacamten. Mavacamten is a drug which has been used for the trial of not HOCM but HCM for hypertrophic cardiomyopathy, and they were quite excited that it is working in these two trials, both Explorer and Maverick trials. But
what do you do for a mitral valve pathology associated with HOCM? If you happen to see a mitral valve, mitral regurgitation, you want to do anything special, or you once you abolish the LVOT obstruction, it will disappear? What are the factors involved that determine whether you need to treat the mitral valve?
So if mitral valve regurgitation is very severe, then we can consider mitral valve repair in most of the patients.
Yeah, if few, not most of the patients, few patients who got an intrinsic abnormality of the mitral valve, and sometimes the mitral regurgitation is due to simply altered geometry of the left ventricle, right? Some sort of a repair might be needed. Okay. So, for atrial fibrillation, how will you manage? See, one of the important aspects of HOCM management is prevention and treatment of atrial fibrillation. You want to address it separately, or how do you treat? What is the problem with atrial fibrillation?
So treatment of HOCM primarily reduces heart failure, AF risk, sir. Otherwise,
the current observation is atrial fibrillation enhances the embolic stroke risk. It doesn't really alter much of the long-term outcome of the HOCM. So you may need to take care of with anticoagulants or your new novel antiplatelet agents that will be sufficient in patients with atrial fibrillation. Okay.
I'd like to see the CHARSA score before giving anticoagulant if there's atrial fibrillation, Ajit.
Does it apply here?
in HOCM patient, if AF is documented, then CHARSA score is not required, sir. We can give them a
very good. No need to do CHARSA score. Straight away you can start anticoagulation.
So this particular patient already partially treated, came with ICD. So most of the things are over for you, the treatment. Only thing is you have to improve the functional class for this patient. Sir was asking about right ventricular involvement. How does it alter the prognosis, right ventricular
involvement? Very small percentage of patient can have right ventricular involvement, sir. And the prognosis is poor in patients with RV English.
That's hypertrophic cardiomyopathy. What is the longevity in adults? What is the natural history of hypertrophic cardiomyopathy?
So in mean survival is around 56 years.
Or how much it's affected? Prognosis.
Sir, mean survival is up to
not
56 years. In natural history, most of the patients will have mortality 1% per year, and most of the cause is SCDs, around 50% of the patients. Second is heart failure and stroke. These are the important causes of mortality.
How many family members for this patient?
Single patient, sir.
Children?
Single one. No siblings, sir.
No sibling. Okay. How if somebody wants, how do you see if father is having a hypertrophic cardiomyopathy? What are the screening methodology you use?
Among the first degree relatives, sir, if siblings are less than 12 years, usually HCM screening is not required. Between 12 to 18 years, yearly echo evaluation is enough. And if they do not develop after 18 years, chances of developing HOCM is less.
Yeah. Screening means you are talking about imaging or genetic screening?
Imaging screening, sir, echocardiography.
That can be done. That's not an issue. You can always screen. Genetic. What is the current role for genetic screening of the patients? Somebody is asking if you. Abhijit. Can you come again with the question, Abhijit?
Before that one, Haresh Kumar has asked whether TMT is contraindicated. I don't know if you have answered it. Actually, it's not really contraindicated. You have to do with a lot of caution. In fact, TMT, if there is hypotension on TMT, it's a strong indication of LVOT obstruction. So we have to be very cautious in TMT. But routinely, we need not do a TMT in HOCM. Then Abhijit.
One more probable indication is labile Hockhams. Probably, I don't know, sometimes provocable gradients we are talking about. How to provoke a gradient to find out whether the gradient increases with exercise also. In that case, it comes into the next risk.
Comes into play, correct.
So my question is, sir, whether we should do dual chamber ICD in such a patients if they need a repeat alcohol septal ablation or
Sir is there, Dr.
Murli is there.
Good question. The issue is two here. One is sudden cardiac death prevention. Certainly, a single chamber ICD will be sufficed most of the time. But for arrhythmia detection, for suppose a patient has a frequent supraventricular arrhythmias, though you would like to avoid inappropriate shocks, all the situations dual chamber ICD will be preferable. So you decide on the logistics and other issues. For example, this patient, we prefer single chamber only due to the acceptance what the patient wanted after discussing in detail. There are centers in the world who do only dual chamber ICD, but there are other centers where they prefer single chamber. As a point to understand this, subcutaneous ICD, one of the indication hypertrophic cardiomyopathy, where there is no need for a Brady pacing. You can even put subcutaneous ICD, which is essentially a single chamber ICD. So single chamber ICD is not a bad choice. Dual chamber ICD may give an extra luxury in selected patient. You can employ that option. Hope I'm clear.
Fine.
Thank you, sir.
What is the chances of hypertrophic cardiomyopathy end up as dilated cardiomyopathy in the later phases of disease?
So 2 to 5% of patient develops dilated cardiomyopathy later in burnout HOCM patients.
Yeah. Burnt out cases they call, sometimes they land up with dilated cardiomyopathy.
That becomes very difficult.
Have you heard of indications of
sometimes post ablation also they can become like dilated cardiomyopathy if you ablate too much of the septum. So
Murli, do you have anything more or concluding comments?
We can conclude now. Sir, I would request you to conclude. Bala,
so before that, Dr. Amit, are you satisfied with our discussion? Are you happy that we have taken the candidate through?
Great learning for me also, sir.
Okay.
Learning from all the seniors, it was a very pleasurable and great academic experience. Really, sir. Thankful to Upati who involved me in this, and I look forward for future endeavors. I would now request you to kindly summarize and.
And Ashish, please send me your email. I'll send you some slides on HOC for your
Sir.
exams.
Thank you, sir.
Okay, okay.
Thank you.
Harish raised a hand. You can talk.
Yeah, Harish.
So why not septal ablation here, sir?
Actually, we can consider when the symptoms are now it is class 2 now, Ashish.
Sir, class 2, but there is some discrepancy, sir, in there is basal scripts are there. That is the only issue with this history presentation. But otherwise, presentation wise class 2 only. So we need not consider alcohol ablation at present. This patient.
The gradient is high, sir.
But gradient even more than 50 is considered in symptomatic patient or refractory medical treatment only. It's very clear the recommendation both for alcohol or even Morrow procedure. Venkatesan is here was talking about Morrow's procedure also both. Because the negative side should be borne in mind. Number one is the arrhythmic risk doesn't come down. Though there was an initial worry whether the arrhythmic risk will go up by keeping a scar there, that was not proved or unfounded. But you are not going to achieve anything in sudden cardiac death prevention or other things. And even the basic pathology of HCM worsening. But the severe obstruction, yes, you can do. You need to do a really good study of the septal vasculature using a contrast echo, exactly locate and do. That's why in the standard center, they do very infrequently unless the patient really deserves it.
One more query. Dr. Satyamurthy, sir.
He's asking about the effect of alcohol septal ablation, the risks involved. Can Ashish, can you talk on that?
Sir?
What are the contraindications? That is the main question.
Contraindication to septal ablation.
Yes, yes.
Yeah.
Sir, compared to myomectomy, septal ablation carries more risks of CHB, sir. So in patients of mainly for septal ablation creates LBBB, and likely that patient of RBBB will goes to complete heart block. So RBBB is one of the contraindication. And in young patients, specifically if patients are very young, then those patients will have chances of other complications due to septal myomectomy is more. So in age is also, if patients are around 50s, then we should consider for septal ablation.
Okay.
Dr. Murali, I have somebody told there is an RF ablation procedure done by Dr. Narasimhan.
Yeah, we have done also. I mean, few cases.
What is the principle behind that?
Yeah, principle behind is giving linear lines of ablation in the septum. So let us think like outflow tract, the septum bulges when the mitral also starts anti-motion the obstruction. Idea is flattering the septal bulge. So typically we used to draw 3 to 4 lines in the septal aspect of the LV with the EnSite or Carto mapping, locate your substrate. Though by linear scars you create, the septum mount like something like what we do for our myopic eyes. You create linear scars that makes it flat, reduce the gradient. That's a novel thinking, not a great number was done. In fact, one of our patients also we did with Narasimhan sir, but it is also not taken up very well because we are looking for a real patient where there is a contraindication.
And RF ablation lesions are very small, no? I mean, millimeters, it will be very difficult. I think with new technology coming, like cardioporation and all that, you might be able to do better. Right?
They may be better, sir, definitely, sir. In fact, for septal ablation, one of the most important things, you need a suitable septal artery. Suitable septal artery is a must with a limit of collaterals, a proper imaging is must. Otherwise, inject it, you may give them an infarct along with obstruction, which is a very bad combination. So you should infarct only the muscle that is causing obstruction.
Correct.
Okay.
Definitely. What's there?
Hello.
summing up.
It's a nice discussion, sir. Thank you very much, sir. We had a wonderful time. Venkatesan, you want to add any concluding remarks?
No, HOCUM, of course, there are two aspects. One is HOCUM is kept as an exam case. So we are discussing in that orientation. For the patient perspective, of course, it can present, as I say, bimodal, whatever presentation, how to improve the prognosis once you diagnose. And all these issues need to be addressed. And with the recent developments, as you say, the alcohol ablation, whatever RF ablation, I think we should go ahead with the further research or whatever it is. So that we can improve.
Like Bala sir elaborated this Movacampton something which comes as a MICE inhibitor. If they are all going to be successful, it will be a wonderful thing for the patients.
Yeah, there is another very interesting concept. The Chinese people, of course, you have to view it with a little bit of trepidation. Chinese. It's called MYBPC3. That is one of the genes, no? So they have been modified the gene using a CRISPR technology, and this has resulted in HCM disappearing. I doubt whether these are all true or not, but it's an open field to a very exciting field of HOC.
Yes, sir. Yes, sir.
Thank you, Murali, for having us.
Thank you, sir. In fact, I should thank Dr. Amit, Murthy sir, Bala sir, Venkatesan. Thank you for being with us. It was a real learning session to all of us. And my special appreciation to Ashish. You did a wonderful job. We are very happy the way you presented. Keep it up, and our best wishes for your future. Okay, good luck, dear. Thank you very much, Dr. Amit. Thank you.
Thank you to Alchandra sir.
Thank you so much.
Murthy sir.
Thank you, sir. Special thanks to you, sir.
Thank you. And okay, Amit. Thank you, Murali.
Have a good day. I think the